infants in 198 and 2012. And this is 9080. This is 9080, and this is 2012. And here is Bulgaria. Bulgaria is around 8.2. The data, and where is Greece? Greece is a little bit higher. Here is Greece, and here is Cyprus. And this is the average for EU countries. And this is also the more recent data, 2018. Low birth weight infants as a proportion of total live births. This is 2018 or latest available. And here is Bulgaria. I mean, it's at the same level. And where is Greece? And this is also Greece. I think there are no changes. This is South Africa, the higher. And the lower all in this left side of the figure, it's Estonia, Finland, Sweden, Latvia, Iceland, Norway. They're around 442. Very good healthcare system, and very, I mean, people are practicing very healthy lifestyle. They're exercising and they have maybe more healthier habits. And this is the trends of low birth weight infants selected in selected European countries. And look at the trend. This is Finland, very low. Finland is the best regarding the healthcare system and also educational system. They have some specific requirements, of course, not very appropriated, not very appreciated by our countries, for example, but this is really a very good success. The red, this is the EU, average for EU, and this one is, I think this is Spain. Look at this, it's improving. And this is Greece, unfortunately. There is a positive trend. It means the low birth weight children are increasing. And Poland is also in a good situation. And so countries are different, and this is not only nutrition that can make the picture and can allow us to compare these figures. Goals for of low birth weight, poor nutrition from mother's side, poor nutrition, dieting, micronutrient deficiency, very high caffeine consumption. Extreme coffee consumption increase the risk of fetal death, and when 200 milligram caffeine for pregnant women, not more than, this is the upper limit, 200 milligram caffeine. And also hereditary diseases, smoking, drug and alcohol use. And these are some figures about the content of caffeine in different coffee drinks. American coffee, 154 milligram, espresso 100, instant coffee between 25 and 27 and 173. And it's interesting that also black tea and green tea has a substantial amount of caffeine, and in black tea it depends on the time, on the duration of brewing. And black tea is around 70 milligram. It means that not more than 3 black teas per day. Effect of malnutrition, nervous system defects in the embryo, child poor dental health, adolescents and adults vulnerability of infection, and higher risk for diabetes, hypertension, stroke, or heart diseases. What also, not only nutrition influence the child development and the situation with pregnancy, the pregnancy status during pregnancy, the conception time, environmental toxins, dioxin, polybrominated biphenyls, and other industrial products affect fertility. Because many of these molecules have structure similar to testosterone. and estrogen molecule and have been shown to be incorporated in biochemical pathway. And both elevated plasma homocysteine and deficiency in vitamin B12 are associated with infertility and recurrent fetal loss. Do you remember which foods are good sources of vitamin B12? This is foods from animal origin, and that's why yes, meat. And that's why a vegetarian who avoid eating, who excluded meat from the diet, they are at higher risk for megaloblastic anemia. And that's why, especially during pregnancy, it's not recommended to exclude, yes, also eggs and meat. Sure, and this is the recommended weight gain during pregnancy, depending on the pre-pregnancy weight. It depends. This is healthy weight. Is between body mass index between 18.5 and 24.9, and the recommended weight gain is between 11 and 16 kilograms for the whole duration of pregnancy. It means that 0.45 kilo per week after the third month of pregnancy. It means during the second and third trimester of pregnancy, because it's not recommended, or it's normal not to gain weight during the first trimester of pregnancy. Underweight less than 18.5, it's the recommended is between 12 and 18. And if the woman is overweight, between 7 and 11, and obese, 5 to 9 kilograms. It means that it's much better. This weight gain ensures normal development of the child. But there are another reason that, for example, obese women, they give birth to very small babies, because there is a placental insufficiency when there is some problems with the blood flow between the mother and the child, and that's why it's very common, overweight and especially obese women, to have a very low birth weight children. And this is factors placing pregnant women in nutritional risk. Young adolescents have had many previous pregnancies, 3 or more to mother under the age of 20, and 4 or more to mothers aged 20 or older. Have a short interval between pregnancy. This is so-called spacing, and this is before less than 18 months, 1.5 years. Lack nutritional knowledge, have too little money to purchase, economical reason, of course. Ordinary consumption of inadequate diet due to food fadism, preferences, weight loss dieting, uninformed vegetarianism, eating disorders, smoke cigarettes and alcohols, are lactose intolerant, have some chronic diseases, are underweight or overweight, are carrying twins or triplets, gain insufficient or excessive weight during pregnancy, and they have a low level of education, and the low level of education can include everything mentioned already. How the energy requirement change? The energy requirement, additional energy is required to support metabolic demands of pregnant women and fetal growth. Metabolism increased by 15% in pregnancy. During the first trimester, the energy requirements are unchanged. That's why it's not recommended to increase energy intake. During the second trimester of pregnancy, the requirements are increased with by 340 to 360 kilocalories per day, and then in the third trimester, plus 112 kilocalories per day. This is not too much. This is 1 sandwich and half a glass of milk in addition. Actually, in the third trimester, the increase is around 500 calories, but of course it depends on the physical activity of the mother. If there is a change of physical activities, I mean, if she stay at home without any exercises, the energy requirements can decrease or lower. Severe energy restriction increase the ketone production. This is very important, especially for during the pregnancy, because after the overnight fast, the maternal blood ketone body concentration are greater in pregnant than in non-pregnant women. This is very specific for pregnancy, ketogenesis. Ketones are a result of fat metabolism and are suspected of being more detrimental to the fetus in the pregnancy, complicated by insulin-dependent diabetes mellitus. And women with diabetes, if they have a chance to become pregnant, they manage to be pregnant. There are very specific, they should be put under very specific supervision and control, because this is a high risk. Proteins. There is an additional requirements of proteins to support the synthesis of maternal and fetal tissue. Protein requirements increase substantially during the third trimester of pregnancy, and during the first trimester of pregnancy, the increase is 1 gram, during the second 9 gram, and 28 gram for the for the third trimester. You remember that non-pregnant women, females, they have a requirement 0.85 gram per kilogram body weight per day. But if we want to increase the protein intake during pregnancy, it's not recommended protein supplementation. It's discouraged during pregnancy. The best one is to increase good sources of healthy proteins, like fish, low-fat milk, low-fat cheeses, curd, and poultry, of course, white meat. Average requirement for carbohydrates are between 135 and 175, but it's easier to remember that it's between 45 and 60 energy% from the total diet. The recommended amount to provide enough calories in the diet to prevent ketosis and maintain appropriate blood glucose during pregnancy, it's 175 for pregnant women and 210 for lactating women. And fiber, you remember, 25 between 25 and 28 grams per day. This is easy to be reached. Especially for some specific vitamins, certain vitamins have particular significance in the optimal pregnancy outcome. They can be supplied during diet and others through supplements. Periconceptional multivitamin supplementation reduces the risk of heart effect by 43%, but not when begins in second month in pregnancy or later. So this is the end. Second month is the end of the embryonic period, because the most important is pre-pregnancy supplementation and supplementation with some minerals and vitamins during the first 8 weeks of pregnancy. And this is the incidence of deformities during the pregnancy with or without supplementation. This is the this is the embryonic period. And children, this is the first 8 weeks after conception, and children are very vulnerable to deformities. So it is very important to ensure adequate intake of all key vitamins and minerals. And this is the risk for children who are supplemented, and the risk who are pregnant women who are supplemented and who are not supplemented. So you see how much higher is the risk for deformities if there are not enough intake of vitamins and minerals. Folic acid is the key of vitamin, one of the key vitamin. During a requirement during the pregnancy are increased for maternal erythropoiesis because it supplementation reduce the risk of megaloblastic anemia, also for fetal and placental growth, and for the prevention of neural tube defects. The recommended dietary allowance is 600 micrograms during pregnancy. And it comes from supplements, 400 micrograms from supplements in the form of folic acids. And folic acid in the supplements has a higher bioavailability compared to folate in food. And from food, it comes around 200 micrograms from diet. And folate are in green leafy vegetables, in cabbage, in egg yolk. So it's important, but it's not enough. And that's why it's recommended if there is a planned pregnancy, the woman to start supplement. The woman to start to supplement to take folic acid at least 3 months before the planned conception. And this is the spina bifida, and the higher the protrusion, the higher risk. This is the protrusion, defective vertebrae allow spinal nerves to protrude. And if there is higher here somewhere, the protrusion, there is higher risk of fatal outcome because it's not possible to survive. Because this is a so-called anencephaly. Vitamin B6 for synthesis of non-essential amino acids. Ascorbic acids, the deficiency increase the risk of preeclampsia. And also the fat-soluble vitamins are absolutely required during pregnancy. And that's why there's special formula of multivitamins and minerals that are supplemented for, especially designed for pregnant women, in the doses especially appropriate for them. But preliminary good nutrition and preliminary supplementation with some vitamins and minerals, for example, iron deficiency anemia. Iron deficiency anemia is common during pregnancy because the requirements for iron, they increase twice from 15 to 28 milligrams per day during pregnancy. And sometimes it's very difficult to reach this high level only from diet. And that's why if the woman is with anemia before pregnancy, this anemia should be treated and normalize the level of hemoglobin, but not only the level of hemoglobin, but also the level of ferritin, because the ferritin, you remember, or I don't know if you remember, but the ferritin is an indicator for iron stores. So it's possible to have low iron stores, decrease iron stores, and not to have anemia, not to have low hemoglobin. That's why the most important is when correcting anemia to check together with hemoglobin in blood the ferritin in serum. Calcium requirements are the same as for non-pregnant women. During pregnancy, the absorption, and this is because there is an adaptation in the absorption and utilization as a result of adaptive mechanism. And that's why there is no reason to increase the intake of calcium. It's between 1,000 and 1,200 milligrams per day. I mentioned already iron requirement. They increased, additional supplementation with iron is required. And usually it's practiced, especially for risk women with low body weight or with preliminary anemias, or with small spacing between two pregnancies, or also with twins, pregnant with twins or triplets. Iodine increased from 150 microgram per day to 200 microgram per day because there are increased fetal demands, especially during the first 8 weeks after the conception for the brain development. And that's why it's absolutely important to correct or to supplement, especially in the region or in the countries with low iodine in the environment. So otherwise, iodine is supplemented because pregnant women should reduce their salt intake. And for example, in Bulgaria, the main part of iodine comes in diet comes from iodized salt. And pregnant women are recommended or are advised to reduce salt intake, sodium chloride intake. And that's why supplementation with additional 150 microgram, it's usually recommended by specialists. This is the summary of nutritional care during pregnancy. Energy intake to meet nutritional need and allow for about 0.4 kilogram weight gain per week during the last 30 weeks of pregnancy. It means second and third trimester. Protein intake to meet nutritional needs, about an addition of 25 grams is an average gram per day. Sodium intake not more than 2 grams per day. This is 5 gram sodium chloride. Folic acid supplementation during the first 3 months. Alcohol omitted, of course, and caffeine restricted in moderation, less than 200 milligrams per day. This is 2 cups of coffee or 3 cups of tea. And this is a suggested menu during pregnancy with enough folic acid, calcium, protein, orange juice with oatmeal, with whole grain toast, cheese, also mid-morning snack with non-fat milk again, and fruit. Lunch, turkey, green salad, fresh peas. One standard portion size of turkey or poultry is 85 grams. So this is the standard portion size. For pregnancy, it's a little bit higher in order to ensure this protein intake. And the standard portion size are not very well accepted or not appreciated in Bulgaria because people like to eat much more. In the afternoon again, non-fat milk, and mid-afternoon snack again, fruit or milk, and dinner baked chicken breast, baked potatoes, peas, carrots, green salad, dressing, fresh strawberries, so fresh fruits and vegetables, and source of fibers, of course, source of calcium, source of protein, and not too high energy intake. And now nutrition during infancy, the length of gestation, the mother pregnancy weight, and the mother weight gain during gestation determined infant's birth weight. After birth, the growth of the infant is influenced by genetic and nutrition, especially during the first year during the first year of life. Nutrition is the key factor that support normal physical and cognitive and also cognitive development of child. Nutrient need of infants reflect traits of growth, energy expended in activity, basal metabolic needs, and the interaction of nutrients consumed. And of course, the adequacy of infants' nutrient intake affects their interaction with the environment. Children with stunting or underweight, they have low physical activity. They can delay the cognitive development, not only physical, but also the late cognitive development. So nutrition is very important, especially during the first months and first years of life. An effective method for determining the adequacy of an infant's energy intake is to monitor gain in weight, length, and weight for length for age, and to plot this data on the growth charts. I'm sure you know this WHO growth chart. They monitor length and weight compared to international. They used to be compared to international standards for age and gender, and place the child in percentile. And this is an example of weight for length for boys, and the normal is between 15 and 85th percentiles. So this is the norm. Infants lose about 6% of their body weight during first few days of life, but regain their body weight by the 7th to 10th day. Infants usually double their birth weight between 4th and 6 months of age, and triple it by the age of 1 year. And they increase their length by 50% during the first year of life and double it by 4 years. So this is the criteria you should remember for the test. Total body fat increased rapidly during the first 9 months, after which the rate of fat gain tapers off through the rest of childhood. So the faster speed of development is during the first 12 months of life. Of course, it's during the intrauterine life, but once come to life, it's during the first 12 months of life. Total body water decrease through infancy from 70% at birth to 60% at 1 year, and in adults is 50%. It's very important, the hydration. Especially, it's very sensitive to dehydration during the first year of life. Changes of body proportion. This is already at the 12 years of life. This is the puberty already, and you know that they have more or less normal proportion. At the beginning, the head is 30% of the whole body, and this is actually embryo, and this is the newborn. This is 25% of the head from the. This is the proportion from the whole body size. Energy and nutrient requirements for infants. What is important, especially for infants, to ensure normal growth. And that's why every dieting or restricting can have a negative impact on the normal growth of the child. Breastfed infants to set a satiety and formula fat standards formula, providing 20 kilocalories in 30 milliliters. So there are standards. Breastfed infants, they control, and that's why they are less. They have less risk for overweight or obesity, because they control their milk intake. Protein need for tissue replacement and growth. Recommendations are based on the composition of human milk, and it is assumed that the efficiency of human milk is 100%. This is the bioavailability and the adequacy for growth. The efficiency is 100%. Protein in human milk provide a major portion of protein for the first 6 months of life, and that's why exclusive breastfeeding is recommended during the first 6 months of life. Previously, recommendation by WHO was between 4th and 6th months of life, but now it's recommended exclusive breastfeeding for the first 6 months. Protein, the recommendation, you remember that for adults it was 0.85 gram per kilogram, During the first 6 months is 131 per kilogram. Then it decreased slightly 1.2 to 1.14, and at the age of 2, it's 0.97. Larger percentages of essential amino acids. Histidine is essential for infants, but not for adults, for example. The protein in human milk is adequate for the first 6 months of life, even though the amount is less than in infant formula. In the last 6 months of first year, diet should be supplemented with additional source of high quality protein. Yogurt, strained meat, cereals mixed with formula, and also egg, especially egg yolk. For infants less than 1 year, recommendation is minimum 30 gram fat per day. This is presented in human milk is small and most infant formula. Low fat intake can reduce the energy intake, and essential fatty acids in human milk are linoleic acids and linolenic acids, and long-chain derivate arachidonic and docosahexaene acids are important. Linoleic acid is essential for growth and thermal integrity, and the recommendation is 3% of the total energy intake, and alpha-linolenic acids is precursor of the omega-3 fatty acids, are important for visual and neurological development, and the recommendation is 0.5% of the total energy intake. What about carbohydrates? Carbohydrates, they supply between 45 and 60 or 55 to 60% of the total energy intake during infancy. During the first 6 months of life, 6 to 12 months of life, 45 to 55, and then between 45 and 60, this is the same as in adults. 37% of the energy in human milk comes from lactose, and 40 to 50% of the energy in infant formula is derived from lactose and other carbohydrates. And there is a restriction: honey and corn syrup should not be fed to infants younger than 1 year of age, because they have not developed their immunity to resist botulism spore development. And that's why in the recommendation for kindergarten and for the individual mother, not to give honey, even not only for infants younger than 1 year, but also for children between 0 and 3 years of age. And water. About human milk and formula supply adequate amount of water under ordinary condition. The water requirements for infants are calculated as 1.5 milliliter per kilocalories per day. And it means that it's around 1 liter per day, but it's, of course, here is include the mother milk also. The renal concentration capacity of young infants is less than in older children and adults. They may be vulnerable to developing a fluid imbalance, small size, and fast metabolism. In a very hot, humid environment, infants may require additional water. And when extrarenal loss of water are high, for example, vomiting, diarrhea, replacement of water and electrolytes is absolutely required. And about minerals, and then we'll take a little bit break. Iron is the mineral of highest concern for infants because milk is a poor source of iron. Full-term infants are considered to have adequate stores of iron for enough growth to double their birth weight at approximately 4th month of age. At 4 to 6 months of age, infants who are fed only breast milk are at risk for developing a negative iron balance and may deplete their reserves by 6 to 9 months. And that's why it's very important to control or to introduce new foods once a child is 6 months old. because this is one of the preventive measures for iron deficiency anemia. Iron in human milk is highly bioavailable. However, breastfed and formula-fed infants should receive an additional source of iron by 4 to 6 months. Iron fortified cereals and iron fortified formula or food, good sources of iron, for example, meat. Iron deficiency, this is the most common nutrition deficiency in young children, especially between 6 and 9 months of life. Can lead to development delay, exacerbate attention deficit hyperactivity disorders, and is associated with lead poisoning because anemia increases the absorption of lead. Toxicity, leading cause of death in children under age of 6, and occurs because iron can build up a tissue and organs. Ingesting 200 milligram of iron can be fatal. But this is by accident. And the consequences of iron deficiency anemia, the long-term cognitive effect of iron deficiency, low hemoglobin concentration at the age of 8 months, correlates with impaired motor development at 18 months of age. Children with chronic iron deficiency in infancy manifested long-term development deficit and behavior issue in early adolescence. Follow-up studies from preschool age to adolescence report poor cognitive, motor, and social emotional function, as well as persisting neurophysiological differences. And that's why iron is one of the so-called social deficiencies, social micronutrient deficiencies of social importance. In developing countries, iron, iodine, and vitamin A, and now zinc also is included, are the micronutrients of concern. And vitamins, commercially prepared infants formula are fortified with all necessary vitamins. Human milk derived from an adequate fat lactating mother supplies all the vitamins that are termed. The term infants need except for vitamin D. That's why from the 2nd month of life, supplementation with vitamin D drops starts, not only for winter-born children, babies. Breastfed infants should receive a vitamin D supplements or be exposed regularly to sunlight. And the daily dose is 400 international units per day or 10 microgram cholecalciferol. Sunshine, exposure, ultraviolet, exposure to 30 minutes per week with infants wearing only a pair of or 2 hours per week if fully clothed without a hat is enough to meet vitamin D needs, but not in winter, of course. And advantage of breast milk. Would you like to make a break? We have found we are on the middle of our presentation. Okay. Let's go. Let's start at 2:30. Just relax, because I like the advantage of breast milk, and usually I'm including this in the test or in the exam questions. So go and refresh yourself, and meet you at 2:30.